Welcome to HealthcareNOW, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. HealthcareNOW is brought to you by High-Tech Answers and HealthcareNOW Radio, part of the Answers Media Network, and is sponsored by the law offices of Myrick O'Connell. Now here is your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Dr. Sarika Aggarwal from Beth Israel. Welcome, Dr. Aggarwal.
Hello, how are you this morning, Matt?
Doing very well. It's great to have you on the show.
A pleasure to be here.
So before we dive into the main part of our conversation, I always like to give my guests a little bit of a chance to provide a little bit more background in terms of who they are and what they do.
Sure. So I am the Chief Medical Officer of the Beth Israel Deaconess Care Organization. This is an accountable care organization in Massachusetts. We are on the eastern seaboard of Massachusetts and really are a network of hospitals as well as physicians, about 550 primary care docs, a total of 2,600 docs. And we are accountable for multiple populations in the commercial, Medicare, and Medicaid space. So my job here really is to strategize the population health strategy, to really understand what the different populations are like, to understand the contracts, the performance metrics, and then to really create programs and tactics, implement them, and really manage the performance, both in the quality and the efficiency space. So pretty much that is 7 days a week, 24-hour day job.
And I'm sure that is probably selling it short from the amount of time as well.
You know, I love what I do, so I guess the time just goes by and I pay no attention.
Yeah, no, I think that is great. It's, you know, when you're passionate about what you're doing, as you said, it doesn't feel like work, and then you don't even realize how quickly the time goes by. But kind of, I think before we kind of unpack everything that you said that you work on, I think, as part of the introduction, we said that you're a doctor. So instead of asking the question I usually do, which is, how did you first get into healthcare? I want to kind of ask the question of, how did you decide to transition from full practice to this more administrative management side with the focus on all the different population health and kind of value-based care initiatives that you were just touching upon?
So I'm a primary care physician. It's my first love and will always remain that way. I continue to practice. I think it's important for physician administrators to really keep their true north. In my mind, the patient first care, especially in the administrative, jobs. I really started primary care, my practice, first in private practice and then employed in 1992. So I've been doing this for a while. I continued doing primary care till 2016. And I continue to practice since. I don't have a primary care panel because, it's hard to take care of patients if you're not there enough. So I do episodic care, but I really think it is important, and it's important especially to me. So I transitioned into administration about 10, 15 years ago, in really first being really cognizant of efficiency in my own practice. When I was in private practice, it was really paying attention to the bills and the lights. And then as I transitioned into the different roles, it was really a very natural progression. I was always interested in PDSAing all my operation and my workflows. So I started with myself, then I, did it for my practice as lead physicians, then for my pod as medical directors, then for several pods as medical directors of the system. So it just was a natural progression, and I kept my practice going, just, dialing down a session at a time. And so there really has been no break in the practice and the admin as I've gone along.
So kind of coming from that clinical perspective, as you said, figuring out practices for your own delivery of care, what were some of the more important aspects that you focused upon as you be in that transition away from the old kind of fee-for-service model to a more data and analytics and quality-focused style of practice?
So I really think that, we talk a lot about the population health and about value-based care. And I think that in a sense, we are still taking care of patients, and I think it is very important that the basic operations of a practice are still important. So practice redesign is still the cornerstone of the care that we are going into now, which is value-based care versus sort of the fee-for-service volume-based care. Because if you do not have the first pillar, which is access to care, everything else does not fall into place, or I should say, falls apart. So I do think that that is the piece that continues to need to be emphasized on, and that's the piece that it really is important now, because what we do is really around the access and the cost and the outcomes, and bringing patients in, getting them to be seen, I think is really the first door to success.
So how do we go about addressing some of those access issues? Because from the outside, one of the things that you hear is if you switch to value, it's going to improve access because you don't have to worry about churning patients through. But at the same time, so my wife is also a primary care physician, and the first place that she worked was very focused, kind of pretty far down on the value-based care side of things. And the access issues actually were not necessarily solved because with the value panel, they wanted bigger panel sizes, which meant more people wanting to come in just because there were more people pushing for it, whereas she's now back in a traditional almost fully fee-for-service practice, and there hasn't really been any change in terms of the number of patients wanting to come in.
So I think that we are sort of in the caught between the crosshairs, primary care physicians, but physicians in general, in that we are in this sort of revolution, evolution stage. So we are transitioning from fee for service, but we are still, I think, majority of our practices are there, going into value-based care, which is, gradually increasing. All the other elements that need to occur along with this transformation have not all transitioned in. So, for example, the physician panel size, the physician productivity, the compensation, the incentives, the infrastructure, the data analytics, the point of care analytics, all of those pieces have not all fallen into place. So physicians really are in that difficult position. And this isn't just primary care, all of the physicians where, they have one foot on the dock and one foot, in the boat. And so I think as an administrator, one of the, in the value-based compensation world, in the value-based care world, one of my responsibilities is to really try and accelerate bringing in patients under these payment models, because the larger the population and the larger the number of patients that come into these models, the greater is the physician in the ACO, greater is their practice under this model. So we can then fund the infrastructure, we can fund the care team, we can alter their compensation models, we can create the incentives. And so, if you think about it, you need at least 50%, if not more, of your practice where patients are in these models. And then you can start changing behavior. And that, I would say, is my biggest hurdle. I think physicians are very engaged. They really understand population health is not just, point of care, taking care of patients, but really outreaching those patients who are not yet sick or who are not yet seen. They just don't know how to reconcile with sort of all of these pieces in the world that they are in. So that is where we are, and we continue to make small steps forward, but that we really we will get to that evolution, and some systems have already done that, where greater than 60-70% of their population is in this value-based care model.
And to kind of hone in on that point that you're making, which is, I think a very good observation, which is you need to get to a majority place where you've got the majority of your patients in these models. How do you go about increasing the size of your patient population that's in these models? And actually, I'll turn that over before trying to go further into the question.
So I think that this is one thing that I think everyone, whichever sort of party you follow is very much in favor of the value-based care model. So I think the public payers and the private payers are all trying to do this. I mean, everyone is aware of the debt that we have, which is largely related to the healthcare costs. And, everyone is trying to really bring populations under, this umbrella. And so states like ours, Massachusetts, for example, they have, if you look at Mass Health, Medicaid, they have about, 1.8, 1.9 million patients in various parts of Medicaid, different payer models. And so they have just brought all the Medicaid standard into this value-based model, and they're trying to bring the Medicare, Medicaid dual-eligible patients into this model next year. There's a procurement. So that every time that happens and the providers participate in it, that brings a whole huge population into this model. And I think especially in the populations, the public payer populations that really require this kind of longitudinal care and care beyond the examining room or beyond the hospital, bringing those into this model really facilitates outcomes, because now it isn't the doc who's just dealing with it, it's the entire care team across the care continuum.
So, and kind of picking up on that last piece, what are some of the ways to promote, or not better, but maybe enhance care coordination? Because I think I definitely agree with you that, as you said, the physicians are definitely engaged in these discussions, and it goes to, I think, how a lot of the reason why people got into medicine in the first place, which is to really be able to help and care for individuals. And, arguably the system inhibited that in the past, whereas now with value, it's getting back to the real core focus of keeping people healthy and delivering the best service possible to a patient.
So, I mean, I think that there are some, core principles to doing this work. I think the lifeblood is really data, which, physicians really had data in one moment in time in the past, in the fee-for-service world. The patient came in, they had data related to maybe their prior admission, and that's it. If they got admitted into another state or whatever, they did not have that data. So I think that is key, the data piece. The connectivity of all the different systems, the ambulatory, the inpatient, the post-acute, even the social service agencies, the community partners, sort of the interoperability of all their systems. I think that is key, not just through the health system, but understanding that patients go elsewhere, through the state, and, maybe eventually through the country. And Medicare, is doing that. So, really that piece. The third piece is, and this is how we would increase access, the standardized way of primary care, approaching primary care, where, you see all the patients, is really the patients, the physicians either are not going to be able to provide access, or they're just not going to be able to provide efficient, high quality care. There just is not enough time. And I think it's adding to the administrative burden and the stress and burnout. What needs to happen is the population needs to be segmented, and really the different segments, and this needs to happen in all primary care. The primary care physicians need to be similar to specialty physicians, which is they are internal medicine consultants. So they get to see a certain population of patients, then the other members of the care team can see the other population. So, a 21-year-old perfectly healthy, college student does not necessarily need to see the primary care, when they come in for their visit. They do need to come in for various things, their immunizations, etc. So there needs to be the segmentation and care directed to the different segments, and that is really how the panel is managed. Or there needs to be primary care practices that are specialized to chronic disease, specialized to we call it the ambulatory ICU, the very, very highest of risk patients that are the super high utilizers. So within medical groups, we need to build this. There are some systems that have done this. I know Geisinger, where, I was working with them in my previous life, has done this. Mayo, there's a bunch of systems that have done this. And so I think for primary care, whether it's family medicine, internal medicine, or pediatrics, there needs to be some of this specialization and segmentation to help with the care. So I think the data analytics, the interoperability, the technology, the segmentation and care management of the different segments of the population. And then really the other pieces are the governance, the leadership, and the financial incentives. The leadership has to buy in. This has to be the true north. You have to believe in this. You have to invest in this. You have to understand that these investments take a while. Any clinical program really takes, 18 to 36 months to really, really show the effects. There is none of this 1 year, start and you get the results. So that takes time, and it takes faith, and it takes trust and investment. And then the providers need their incentives, compensations aligned with this care. So you cannot have your compensation based on productivity and then, do group visits or spend time teaching patients about their diabetes. It doesn't go hand in hand. So I think all of these are pillars on how value-based care needs to be based on. And what is happening is everyone is doing them. Some are going more intensely into a few of them, or they're trying to do it all together, touching the surface. And like I said, it's a revolution. Some are in the evolutionary phase. Some are going through this. I think we're going to get there. I'm very optimistic about it.
And for those of you just joining, I'm talking with Dr. Sarika Aggarwal, and we're talking about transition to value-based care. And you're just talking about some of the pillars that you see to support that and to really make it sustainable. And I'd really like to hone in on the one that you're describing in terms of, and hopefully I'm going to describe this correctly, of doing almost specialization within primary care, because that's the way of framing that is not something that I've heard before, or at least described in that way. And I think it's very intriguing because, as you said, it's really, even right from the start, trying to maximize the delivery of service and the scope of interaction to, it sounds like, kind of getting the patient in front of the most appropriate person at all times. So I would be very interested to hear more about how you go about establishing that and how it runs in actual operation.
So these are really advanced primary care models, and to look at the specialty primary care models, we have a lot of innovators out there. There's IORA that, really caters to the Medicare Advantage population. So it's really, really honing in on that population whose needs are different. For example, for the commercial population with no chronic disease. And so I think really tiering or segmenting the population so that the population that's very healthy, that needs prevention and wellness, you really look at care teams that that are non-MDDO, and you look at a lot of sort of the digital health, adding, you use portals, really to augment the encounters. So I'm not sort of advocating that you decrease the encounters with any segment of this population. All I'm saying is you change the encounters. So the very healthy, you can, do digital health, telemedicine, e-consults. You can sort of check in through the portals. You can send, sort of texting. You can use all of those pieces to make sure that they come in and get their prevention and wellness. Then there's sort of the population that has chronic stable disease, and, you can then, work a lot of the care teams, the nutritionists, the wellness coaches, the health coaches, along with maybe, a few visits with the physician or nurse practitioner consultant. And I'd like to think about them as consultants in that space. And then finally, you have, like I said, the really, the highest of risk, and those need to be seen face to face in addition to all these other modalities. And you see them on a regular basis. So the large part, and the fact is that what is happening is that first and second group is being seen now. The third group, there is no access for them. Or when the second group, which is the chronic stable, becomes acute, there is no access for them. So that is really what is happening. Is we are attending to our panels, our encounters during the day are being filled with, either sort of the top, which is the very sick, or maybe even sort of the third tier. The second tier, which are at risk, stable, kind of the middle of the class, which may be eventually you're very sick. That is the population that we should impact. They need attention and education. And I really think that we are not putting in enough attention on them, sort of, the pre-diabetics. Those are the patients, for example, that we really need to hone in on. I think that it can actually happen in your own practice, but the compensation model has to be different. You do need infrastructure, which adds to the whole population health operation budget. The fact is that some of these things can be done centrally. I do believe in the embedded model, but one has to see what the panel size is for the embedded model. And here's something to think about. One of the things that we always talk about incentives to the physicians being monetary, but lifestyle and quality of life for them is just as important. So incentivizing them with non-clinical folk who can do a lot of this administrative work is just as important as giving them financial incentives for doing this work. So I think that is something to take away, and we definitely have to do that at a slow pace or at a fast pace, but, we need to get there.
Shifting the focus to, as you said, non-monetary benefits really seems to align with a lot of the reports in terms of what newer members to the workforce might be looking for, which, as you said, is that better lifestyle balance, because there is, I think, maybe more general awareness or of a general push to allow for more time outside of a workplace to be able to engage in either family life or volunteer activities or, any other type of thing that is important to each individual.
Yep, I agree.
And then, and also kind of extending that, I think it also ties back to a point that you made in passing earlier on, which was that all goes to addressing what's becoming an increasingly well-known issue of burnout among physicians and others within the healthcare field, just with all of the different pressures that have come on and feeling like they're not able to focus on the areas of practice that are most appropriate for them.
And I think that that is really important, the administrative burden, because physicians want to do what's best for the patient. But what we are finding trouble with, and I'll take an easy example of, say depression. If most physicians have 8 to 10 payers, if not more, that, their patient population, is sort of, it consists of. And I would say that even, and I can speak for, us, that, the definition of what the definition is for the depression and what one needs to do to take good care of our patients with depression differs from payer to payer. And the difference is not in the treatment, but in sort of the how and the process piece. And we are being monitored, or the performance metric is on the process. And so that, I think, is an administrative burden rather than just focusing on the outcome. So that is going to be sort of when we get to, the pinnacle of value-based care, is we will be outcome-focused, and the process can be customized, and the process metrics can be, belonging to the institution. It's really, are these patients getting better? What do you define as better? Do you take the patient's view of what is better? I'm feeling better, I can drive, I can, do my bills. That in my mind is when we will, I think, call it a success. Right now, it's sort of this, all of these metrics that are different and really are adding to the physician burden. They cannot just go back and think, I just want my patient to feel better. What does that mean? And let's focus on one metric based on that.
No, you're definitely right. It's, as you said, having a metric focused on the process is arguably missing the whole point of quality, which is, as you said, are you producing better outcomes? Are the patients healthier? And, each individual should be able to, arguably should have a different path to getting there. Unbelievably, as we're already running towards the end of our time, I'm going to ask you one kind of broad, sweeping, conclusory question, which is, if you could change one thing about the healthcare system now, what would that be and why?
So, this is going to be my personal opinion. I really favor a single payer, national insurance. I think that if you put aside the financing, whether it's, public or, not so public, I think that, that is, really important. The delivery of care does not need to be, with the public agency. I think that should remain in the private hands. But I think that it would allow for what the physician in me wants, which is all patients be covered for medically necessary services, doctor, hospital, prevention, wellness, long-term, all of that, mental, physical, all of those pieces. I think that, it clearly there are many, issues with that, and we can go up north to Canada and, talk about all of those things. And there's a lot of debate that needs to happen. But from, why I became a physician, that really appeals to me, because it would really be, healthcare for all, and patients would not face financial barriers. That really, is something that would allow the physicians again to regain autonomy over, the patient care.
A very interesting perspective and thoughtful response. And kind of, as I said, believe it or not, we are already out of time. I want to thank my guest, Dr. Sarika Aggarwal, for a great conversation today. Thank you very much. Thanks for inviting me. And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.